thank you so much for joining our Q&A session today. So I'm Christie, I'm the Head of Patient Services at the Foundation, and today we've got Dr. Andrew Yeoman with us, which is joining us today. Thank you again for taking your time to be with us. It's really very much appreciated.
Yeah, pleasure,
we've got some questions that have been sent in ahead of session that we can start on, but just before we start, I just want to remind everyone that these Q&As don't take the place of a consultation with your own clinician, and in these sessions we aim to provide general medical information, not medical advice. And also just a reminder that Facebook is a public forum, so just be careful in terms of what you're putting in there, and if you want the privacy of the room, you can join us here and click meeting for the privacy of the room where it's just us here and the chat isn't shared. So if you have any questions for us, please just pop them in the comments and I'll keep an eye for them. But in the meantime, we can just get started on the questions that we have in for today. So the first question that we have today is a patient who's been recently diagnosed with PBC, but is questioning their diagnosis. They're curious if you've heard of people testing positive, but not taking their urso, but doing some alternative supplements, for example, a liver cleanse to clean up their liver, and then a retest could be negative following that. The patient is reluctant to take drugs and has previously had a reaction to PEG and dyes, which seem to be an urso. They think their numbers are low, but they've had fatigue, memory issues, and dry eye mouth for over 11 years, so they don't understand where they would be in the terms of progression. So what would be your advice and any information that you'd like to give on that?
Yeah, important series of questions there, really, isn't it? There's a few things to unpick, and I think the first goes back to whether this person has PBC or not. And I think the key to that, and I know we've discussed it a couple of these before when I've done them with Robert and with Colette before that, is that when we make a diagnosis of PBC, we require a number of different features. So the key things are you need to have a raised alkaline phosphatase level in your blood. So that's part of what we call the liver function test panel. So that's the key biochemical test that we need to see that's elevated. And then we're also looking then for evidence of an anti-mitochondrial antibody in the blood. That's the antibody that is measurable in the majority of people with PBC, although there are about 5 to 10% of people who don't have the antibody but still have the diagnosis. Mm-hmm. Those people is when you're really suspecting the condition. That's when you often do a liver biopsy to try and confirm. But if you have a raised alkaline phosphatase enzyme and your anti-mitochondrial antibody is positive, that is enough to make a diagnosis of PBC. So obviously I don't know all the bits of information for this particular person who's asking this question, but certainly if both of those findings are positive in the blood, that is enough to make a diagnosis of PBC. Now the next question, I suppose, relates to whether somebody should be taking medication for that then. And I think if, generally speaking, as healthcare professionals, we would recommend that the vast majority of people with a diagnosis of PBC, based on those characteristics I've just described, should be offered treatment, although some people do find medication difficult to take because of side effects. So the reason why we recommend treatment is that if people have abnormal liver blood tests and they respond well to ursodeoxycholic acid because they have PBC, then we know that puts them in a much lower risk of progressing their PBC in terms of their liver disease. And that's important that this is about the liver disease now, because I'll come back to this point in a second, because the treatments that we have for PBC don't impact on symptoms rather than they impact on the progression of the liver disease. We have to recognize that some people really don't tolerate some medications very, very well, but there are more than one medication now available for people with PBC. So if this person's doctor really thinks that they definitely do have PBC and would benefit from therapy and they can't take it, so there may be other medications which don't contain those constituents that they previously reacted to, that they may well be able to tolerate well. In regards to prognosis, I think what's important with PBC in terms of prognosis is a number of different factors within that. One is how high your ALP is, and then whether you respond to medication or not. So the higher your ALP level is, the more importance we would place as doctors on treating that to try and reduce the amount of inflammation of the bile ducts to try and prevent progression of liver disease. Because we know that the higher your ALP level is, the more likely you are to develop progressive liver damage in PBC. These medications, though, don't improve symptoms. So most of them don't improve. So urso, for example, doesn't improve itching, and it doesn't improve fatigue. And we know, unfortunately, that none of the medications we've had to treat the PBC directly or associated symptoms really work very, very well for fatigue. So we're still really stuck on that aspect around fatigue. But we do always talk about the importance of physical therapy interventions and sort of movement as medicine, ways of trying to sort of slowly increase, it's difficult, but slowly increase your physical activity to try and overcome the effects of fatigue, which we know can occur with PBC. Dry eyes, dry mouth is something that is not directly related to PBC, but is common in people who have PBC because it is another autoimmune manifestation. So we always come back to this point, is that PBC is a condition where your immune system attacks your liver, but actually the tendency to develop these immune conditions can mean that in one person it's PBC, in another person it could be thyroid disorders, and in some people you can have more than one autoimmune disorder or autoimmune feature. And so some people have this Sicca syndrome where they get dry mouth, dry eyes, and that doesn't mean to say you're more likely to develop progressive damage from PBC. So we know that the presence or severity of symptoms with things that are associated with PBC don't necessarily make you more likely to have severe liver disease. So that's a really long answer to probably what's a reasonably long question. I think so. I'd come back to sort of summarize it to say the important features here are, to make a diagnosis of PBC, you need to have a raised ALP and an anti-mitochondrial antibody. And if you have that, it's pretty, that's concrete. You have the condition. Then the importance of treating that then is based on how high the ALP is and whether you've got significant chronic underlying liver disease. And sometimes they might do additional tests like a FibroScan to try and work out whether there's significant underlying liver disease, and that might provide more of a push to recommend treatments for this condition. But in general, as doctors, if we find that you definitely have this condition, we recommend that people are treated to prevent the future progression of underlying liver disease, but that doesn't impact on your symptoms. So those still need to be managed in conjunction with either your GP, or if it's dry eyes, dry mouth, often the rheumatologists are involved in people with those sorts of problems. And there are some other services that help people with those associated symptoms.
Actually, I'm just going to move to a question that we've had in later, but just touches very much on what you just said there.
Yeah.
And the question is, does urso reduce itching? So I just wondered if you wanted just to say a wee bit more about that before we move on to the next question.
No, it doesn't, and actually it can make it worse. And that's weird, isn't it? Because you kind of go, if this makes my liver better, and and if you take urso and you respond to it, you are less likely to develop progressive liver damage. You would think, wouldn't you, logically, that it would improve your itching, but it doesn't. And actually, in some people, urso makes your itching worse. So it's an important thing to remember. It's a treatment to prevent progression of scarring within the liver. And, we measure the response in the ALP level to try and help guide us whether that is going to do that for you. But it doesn't improve your itching, I'm afraid to say.
Okay, thank you. So just moving on to the next question we've got. So the background is we've got a patient diagnosed in 2017 after a routine blood test. They see a liver specialist every year to check their LFTs. 58 years old, active, no alcohol and otherwise healthy. ALP and AST have always been in the higher normal range, but GGT around 120, and they've never shown any other symptoms. A bit concerned because over the last month after a routine blood test with a GP, they've seen that their GGT has risen to 600 and ALP to 400. Since that, they've also experienced severe pain in the right back shoulder blade and neck for 2 days around that time, which they've heard can be a referred pain from an inflamed liver. Their GP has contacted their consultant after receiving the blood test results back and advised they start urso immediately. One of the things that I'd noted after seeing that question, doctor, was around starting urso now, but the diagnosis was 2017. So in my mind, I was questioning why the delay in starting urso as well. Yeah, and they're just a bit worried if there's anything else going on, because they're feeling really worried and anxious about that.
Yeah, I think certainly the first thing to say in terms of worry and anxiety is that PBC is not a condition that worsens very, very quickly by and large. Okay, so don't get me wrong, it can cause lots of really unpleasant symptoms for you, which can interfere with your day-to-day quality of life and sometimes devastatingly so. But in terms of, you're not going to go from having no damage to your liver, only minimal damage to your liver, to severe damage within a few months. Okay, it takes a long time if that's going to happen. And it's also important to remember that only around 40 to 50% of people with PBC will ever develop cirrhosis, which is the most severe form of liver damage. So a spike in your liver tests might be in relation to PBC. And, I think in that sense, if you have an established diagnosis, I think, that is certainly really important that you are on some urso to make certain that we improve those liver tests as best as we can to reduce long-term future risk. But if they've been low level for a long period of time and they've suddenly jumped up, it's always important to reflect, could it be something else that's done this? Okay. And I think whenever we as doctors are thinking about what those other things can be, we always go back to the patient and ask what additional symptoms may or may not be present. And actually, if you've had pain on that right-hand side, it's possible that you've had a stone. So we know gallstones are more common in people with PBC, but they're really common in the general population anyway. And sometimes it's possible that you might have had a little stone that's got stuck in the duct, because really, when we're looking at that ALP enzyme to see if somebody has PBC and how severe their PBC is not the only cause of that enzyme going up in the blood. So stones stuck in the bile ducts can also cause similar problems. You can just have infections, and it can sometimes irritate the liver. We saw this particularly with COVID in the early stages. It tend to cause a rise in the ALP level. So there's lots of different things, that can cause an elevation like that. And I think generally what we look to do is that if you've seen a sudden unexpected result in association with some other symptoms, it might be that you require an ultrasound scan just to make sure you haven't got any stones or any swelling of your bile ducts as a new problem. And sometimes when you just repeat the tests, often they've just gone back down to normal again. Because it's quite unusual for PBC for the ALP to really fluctuate wildly. I've seen it, but it doesn't happen very, very often. And so it's always important to consider whether there might be other factors there. If your symptoms are better now as well, this will have been a one-off thing, and it might not happen for you again, but it's probably worthwhile, thinking about further investigations to look for alternative causes. But I still agree that treatment with urso is sensible if you've had an elevated ALP and you've got a diagnosis of PBC. So I wouldn't be unduly alarmed at this point in time, but certainly get it checked over. It might be that, especially if you've had pain or that's a recurring pain on that side and the liver tests are not getting better, then your doctors may recommend further tests. But it sounds like there's been communication between the primary care doctor and the hospital doctor, which is appropriate. Yeah. And so things are happening along there. So I would encourage you to make sure you go back to them and just check what the follow-up is with this. When do they want to do your bloods again? And do you need any further tests? And when's your next appointment going to be with the hospital team? Would be the natural questions I would suggest you ask.
That's great. Thank you. The next question we have is around supplements. Will eating Irish sea moss and drinking bladder wrack root tea, which I had to Google, bladder wrack root tea, I hadn't heard of that before, or any other tea interfere with urso?
Yeah, this is always a tricky one when it comes to supplements, because when medications are first developed, they are tested, and how they're absorbed is sort of calculated, but by clinical pharmacists. And they measure the absorption and how much gets into your bloodstream and make sure it's effective and make sure it's safe. But of course, they're never tested in the sense with other chemicals. And certain supplements can sometimes absorb. The classical one is actually grapefruit juice. So grapefruit juice is notorious for interfering with the absorption of lots of different medications. And in some medications, it puts the levels of those drugs up higher. For others, it suppresses them down. So it's always a little bit of a caution in terms of it can affect the absorption of medications like urso. So the trouble is that because they haven't been formally tested, we don't really know. So in general, best to avoid those things unless there's clear evidence that they lead to an improvement in your liver condition. And those things have not been formally tested as being helpful for the liver in large clinical trials. There might be case reports for certain things, but in large studies, these are not things that we recommend people take, because there's never been convincing evidence that they actually lead to improvements in PBC or liver disease generally. So it's just a little caution. Most things are fine. Most things are quite safe, but there are certain these supplements that can sometimes be harmful. Those ones in particular are not particularly harmful to the liver, but as to whether they will affect the absorption of the urso, it's not really possible to say. So make sure that you've had a good few hours at least if you're going to take those things, where you haven't ingested those things, prior to taking the urso, just so you minimize any potential impact for those things in terms of affecting the absorption of the drug.
Actually, there's just a question popped up on Facebook, which is just relative to that, which I'll ask just now, if that's okay. And it's around calcium supplements. Do calcium supplements interfere with urso?
No, they don't, and I think I think it's important that actually we often recommend and often co-prescribe calcium supplements to some people with PBC. I think it's really important. I think there's a diet and PBC question coming up, I think, and I think if there nearly always is. I think it's important that you have a high calcium intake in your diet, but for some people that's not going to be quite enough, and they do require higher levels of calcium supplementation, so they have to take the tablets for doing that. So no, we commonly co-prescribe them. That's not usually an issue. That's
great, thank you. So just moving on to our next question, we've got a female patient aged 46 diagnosed in May 2023 on urso and responding well, however suffering from body, back muscle, joints and bones, and their feet are really aching as well. The feeling is it like they've done too much exercise. They do exercise regularly, running 3 times a week, does yoga for stretches, but it doesn't seem to ease the constant pain. They try to eat healthily, but note that fatigue comes and goes, but not too bad. Blood tests all seem normal, so not related to arthritis and no other inflammation markers present. Are these symptoms common for PBC, and do you have any suggestions as to how I could ease the pain? Any specific exercises or particular diet that you would suggest? So just following on from that as well, which is great.
Yeah. So I think there's no specific diet that's ever been tested to be shown to be helpful for PBC itself or associated symptoms. Although we do recommend people take a high calcium diet, because we know that having a disorder of your liver, particularly one that affects bile excretion from the liver, can develop osteoporosis over time. So it's really important that you have plenty of calcium in your diet. Other than that, there's no specific exclusion diet that's ever been shown to be helpful, or any additional supplement that we have shown to be helpful in PBC. In terms of are these symptoms common, I think actually sort of muscle pain is quite common when you ask people who have PBC. And some of that is related to specific associated conditions, such as Sjögren's syndrome, where the joints can be formally affected. And actually the blood tests don't always flag up with that. So if you're having a lot of joint pains, because it sounds like you're working pretty hard to stay fit. I mean, I don't exercise 3 times a week and do yoga. So, hats off to you. You're clearly working as hard.
Trying very hard, yeah.
Absolutely. So, but if you're having lots of joint pains, despite that, it might well be that you need that reviewed, because if you look at people who have Sjögren's syndrome, which is an autoimmune type condition that affects the joints, the classical blood markers that we see for rheumatoid arthritis are often absent in the blood. So and the inflammation levels like CRP in the blood that we often measure are often not that high. So in some people, then they do need a formal assessment with a rheumatologist, or sometimes it's helpful to get some wrist x-rays to make sure there's no evidence of what we call erosive arthritis. So, most people know about osteoarthritis, which is like wear and tear, where the bones kind of get ground down on one another a little bit. Mm-hmm. But when you talk about rheumatoid arthritis or other inflammatory arthritis, then what you get is destruction and damage to the joint in a slightly different way. And an x-ray can sometimes help differentiate between those two. So I think if the symptoms are really that limiting, despite you doing your very level best to staying physically active, then it probably warrants another review, maybe some additional tests. Sometimes x-rays are helpful. Obviously a doctor can examine you to determine what the appropriate next test can be. But if it's really quite debilitating, then sometimes a referral to rheumatology is important to exclude what we call a seronegative arthropathy. Okay, that's a long-winded way of saying that the blood tests don't flag it up really easily. Thinking back to that AMA and PBC, some people don't have the AMA and PBC. So the same can be in inflammatory joint conditions, where you can get that, but the bloods are not always telling you the full picture. So sometimes a more specialist assessment is sometimes necessary for that. So I think it's always worthwhile looking for those other associated conditions and being as specific as you can. Sadly, some people are left with joint symptoms and muscle pain, which can be associated with the PBC. And, that is pretty difficult to manage other than what you're already doing in terms of your physical activity. So I would certainly say, get some further, ask some further questions of your general practitioner to begin with, or if you're in contact with your specialist, to see if there's anybody else who can help assist, getting to a diagnosis to exclude, a particular joint disorder there for you, because it sounds like the joints are particularly troublesome. The other thing that I would say is often important in PBC is talking about associated other autoimmune conditions, is just having a consideration of testing for celiac disease, because celiac disease is a common autoimmune condition in the general population. You're more likely to have something like that if you've already got PBC, and that can affect bones and joints because it affects calcium absorption. And so, if you've got that, then you're not going to be absorbing the nutrients, including calcium, very, very, very well. And some people do get disturbances of the way the bone is formed, and that can cause sort of chronic low-grade discomfort in the absence of an actual arthritis. So it's an important sort of thing to just consider in people with an autoimmune condition like PBC.
Great. And just to mention on the diet part as well, we recently uploaded an input from Professor Bernadette Moore from our PBC conference, patient conference that we had in September. So that's up on our YouTube channel now as well, if anyone wants to have a look at that. And any problems finding that, just give us a call at the office and we'll point you in the right direction. It's on our PBC TV on YouTube, which is also where we upload these videos after they've been on Facebook as well. We put them up there as well so that patients can see them beyond the Facebook position as well, which is great.
Yeah, and I endorse that. That was a really good presentation, wasn't it? Really, really good.
It was really excellent. It really generated quite a lot of discussion as well within the group of patients that we had there, which was great. And it is something that does regularly come up because people are actively looking, is there anything they can do that could help? Is there anything to avoid, anything to have more of? So no, that was a really great input, and I'd recommend any of the patients to have a look at that. So our next question is around a patient with PBC for 13 years and also hypothyroidism. Up until a year ago, she would experience issues every 6 to 8 weeks with stomach pains, hot sweats, sickness, loose bowels, and then cold and shivers. They cut out milk and eggs following a food intolerance test and has been fine until a very recent recurrence of these symptoms. And they're asking if it could be related to their PBC.
I mean, I have to say this particular set of symptoms doesn't sound particularly PBC related. And I think, that sounds much more like a primary gut type problem. And the sort of constellation or the gathering of symptoms there do sound fairly suspicious for what we call diverticulitis. Okay, so diverticulitis is inflammation of small pouches that are called diverticulum or diverticular, which exist in the large bowel, usually when the bowel's under a bit of pressure. So if you have a tendency to be a little bit sluggish in your bowels, that often increases the pressure in your colon, and that leads to little outpouchings which can get inflamed, and they'll often be associated with fevers, pain, and diarrhea. That's the classical 3 symptoms you get of that. So general sensible advice would be to make certain that your bowels are opening really consistently and reliably at other times, because if your bowels are tending towards the constipation side, then treating that can prevent these attacks from coming on. And so it's really important that you've got a healthy bowel emptying, that you're not having to strain to open your bowels, and that you feel satisfied after you've gone to the toilet to open your bowels, because if you're not satisfied after going, that's a sign that your bowels are not emptying as well as they should and might need a little bit of assistance. But certainly if this is something that's happened, I would certainly pop to see your GP about it, because often sometimes people need another check just to make sure there's nothing else going on there. They don't sound like nasty or sinister symptoms, but actually it does sound like an episode of what we call diverticulitis. And if you get recurrent ones of those, often a short course of antibiotics can help. And usually one of the GI or lower bowel surgical teams will want to look in with a camera to make sure there isn't any large pouches there or any narrowings in the bowel that could be exacerbating that sort of problem. So certainly worthwhile reporting it, getting it checked over. And if you're having symptoms like that with the sweats as well, then pop in to see a GP, because you might need a course of antibiotics for that, because that can be quite nasty.
Okay, thank you. So moving on to our next question, we've got a patient with PBC for 25 years and has had for the last few months been suffering with really dry mouth, so bad that it's like they can't produce any saliva at all. They've looked into it and have seen it can be a symptom of PBC. We've touched on that earlier. today as well, and they were hoping for some advice for them as how to combat that, as no dentist or doctor seems to be able to help them. So they're looking for a bit of advice on it.
Yeah. It's really problematic for some people, isn't it, this issue? And I'm sure you come across it a lot in the forums and in the questions that come through to the foundation. And I think we always talk about the fatigue and the itching, but actually I think the dry mouth, dry eyes can be, because it affects your taste. It can, just makes you feel grotty all the time as well. There's not a treatment that improves saliva production, unfortunately, but there are replacement sprays that you can use to try and provide better lubrication. So if it's dry eyes, then liquid tears work really, really well for that, and that's usually manageable. But there are several types of branded sprays. Glandacin is probably the commonest one, but others are available, and they are just literally small little canisters, spray mechanism, and you use them then, particularly around the time of eating, or if your mouth is particularly dry, and they're small enough to be able to be kept in a small handbag or a pocket in a coat, that sort of thing. So you can travel around with them as well. They're not big and bulky things. So those are normal things that we would normally recommend. It's surprising that dentists haven't, no, not all dentists will see a lot of PBC. Of course they won't, but people will probably go to the dentist quite often with dry mouth type problems, and I'm surprised they haven't recommended one of those to begin with. And that's where I'd sort of direct you in the first instance. People can have formal testing for these sorts of problems. Again, they're often done through the rheumatology clinics, although that will vary around the country about who's set up to do the specific testing. But certainly there's no specific treatment that improves the salivary production. But there's plenty of things you can take to try and aid that lubrication of the mouth to help you with your food and swallowing, because ultimately you can't really taste anything if your mouth's dry, and also it's pretty unpleasant having a dry mouth all the time, so it'd be well worthwhile you being on some replacement sprays.
Looking at a solution. That's great, thank you. That's all the questions that we've had sent in, so I'm going to just take some questions that we've got live from Facebook now. We've got quite a few questions waiting for us now. So we've got a patient diagnosed in January this year, and they'd like to know the best time to take their calcium tablets. Also concerned with hair loss and ridges in their nails, which has been getting worse and brittle, and could this be PBC or thyroid, and what test to ask the GP for?
I think you're on the right track already. I think your basic reading has led you down the right sort of path, really. And I think so. First thing, if you look at the brittle nail side of things, then certainly it's really important that you've had your iron levels checked as well, because that can be associated with brittle nails. That's quite commonly seen in people with celiac disease, which I've already mentioned is an associated autoimmune disorder with PBC. So it's important that you get tested for celiac disease, check your iron levels. Just to make sure there's no nutrient deficiencies with that. So PBC itself shouldn't cause brittle nails in and of itself, only if there's other things going on, usually with nutrient deficiencies. So certainly get that done. Do you see what the other point was around dry mouth, was it?
No, they were asking the best time to take their calcium tablets.
Calcium, yeah. Sorry, yeah. So the best time to take the calcium tablets, I mean, generally most people will take them in the morning. Again, it's quite a high dose. It's got quite a long onset of action, so it doesn't really matter too much. It's about when you can remember to take them and when it's most palatable for you to do so, because they're not the best tasting tablets in the world, as most people who've ever had to take them will attest. So make sure it's not interfering too much with your dietary intake, but it doesn't really matter too much when you take them. Okay,
that's great, thank you. We've also got a question around statin. Can they take their statin at the same time as urso?
Yeah, you can, and there's no reason why you can't take a statin if you have a liver condition. There's a lot of anxiety around statins because people have read that it can cause liver inflammation, and yes, it can, but that's actually really quite rare. And what's really clear from the literature is that there's no evidence that having an existing liver condition makes you more likely to develop a drug reaction to a statin. So if you need a statin for cholesterol reasons, then please do take it. Generally speaking, statins are taken in the evening though, and some people might take their second dose of urso in the evening. So if you're on a twice day or 3 daily sort of schedule, but there's no reason why you can't take them together.
Okay, that's great, thank you. this one has a wee bit of background to it, so I'll just read through it for you. So the patient's 10
Yeah.
years diagnosed now and they're 40. They're on 1,500 milligrams of urso, 10 milligrams of obeticholic acid, and ALP is still between 254 and 400, still fluctuations, but mainly high 200s. They're awaiting a DEXA and another blood test. Was ordered that could be done via their ICE system, only seeing the consultant annually, and a check-in with the liver team via phone. Next consultant face-to-face is February. They have cirrhosis after biopsies confirmed, never really had alcohol, and hasn't had a drink in the last 7 years. What treatments could they ask about next? They've also noticed some cramps in their legs at night time and hands too, where their fingers will lock up. What would we be thinking about for next stage treatment?
So it sounds like a good combination of licensed treatments. So that's the ursodeoxycholic acid, or URSO as we call it, and then the obeticholic acid, or OCA as we also call it. Those are the licensed therapies, but there is the potential option to add in bezafibrate, or bezafibrate as some people call it, which is a treatment originally developed for cholesterol problems, but has been shown to have impacts in PBC at both improving liver tests. So getting that ALP down as low as we possibly can. And if you have cirrhosis, then we would want to try and get it obviously below the 200 mark, but certainly the lower you can get it, the better. So that will be one to discuss for sure. The other thing that's also come out in the last few months is that, not just yet, but obviously there's been a couple of studies that have been concluded that are showing promise. And so they're about to go through the regulators now to get approved as official therapies for PBC. So one is ciladelpar and the other one is elafibranor. So there's potentially other new options on the horizon for people with difficult to treat PBC. And I think certainly if you're on 2 therapies and your ALP is still above 200, you're a young person and you've got cirrhosis, that would fall in the category of the people who would be eligible for additional therapies for sure. So that might be something in the probably later half of 2024, early part of 2025. But in the short term, the here and now, then fibrates, so bezafibrate would be the most likely option. And I don't know if I mentioned, but it also has the potential added benefit it can help itching as well in a significant proportion of people. So that would be the route that I think would be most productive to go down.
Great, thank you. Just moving on to our next question, we've got a question around, it came in just as we were chatting earlier about the supplements. So a question around a multivitamin, are they okay to take?
Yeah, I mean, I think multivitamins are generally fine because they are really just very small doses of vital vitamins you need to have. So vitamin A, vitamin B. So they've got multi subtypes of vitamin Bs in there. So you've got some vitamin C in there. Vitamin C can help you absorb iron a bit better. A little bit of calcium, all those sorts of things are helpful. So most of the commercially produced multivitamins all contain those things in smallest quantities, so you're not going to ever get toxicity effects from them. And they're all things that have been used to being given by pharmacists and by medical doctors for different conditions for years. So we know that they're safe and they're well tolerated. So a single multivitamin is absolutely fine.
Great, thank you. And a question, I think it was when we were discussing the patient who had the bad joint pain. If you do have to take painkillers for joint pain, what can you take?
Yeah, really good question. So in general, the safest painkiller is still paracetamol. So a lot of people think if you have a liver condition, you can't take paracetamol. That's simply not true. It's perfectly safe to take paracetamol. It's only dangerous to your liver if you take more than the recommended dose, which is 4 grams a day. So that's 8 tablets a day. So if you stick well within that, you're not going to develop any problems that way around. Now, we talk about the itch treatment ladder. There's also an analgesic treatment ladder as well, and we start off with paracetamol on the lowest rung because it's the safest and it can work quite well for mild to moderate pain. But some people it doesn't work for, so if the pain is a bit more troublesome. Particularly if you have an arthritis condition like rheumatoid arthritis or Sjogren's, you might be prescribed non-steroidal anti-inflammatory drugs, and that is fine for some people. But obviously, you want to try and limit the dose of that because it can cause a lot of GI upset and disturbance, and it even cause stomach ulcers in some people. But if you have more advanced liver disease, or as you get older, certainly above the age of 65, the incidence of sort of side effects from non-steroidal starts to sort of creep up and starts to become really quite significant. So dependent on your age and other associated conditions and the stage of your liver condition, non-steroidals might not be great for you. So if simple paracetamol is not working, have a conversation with your doctor about what the next best option is. If non-steroidals are not an option, then you're looking at drugs like codeine as probably the next sort of one up the ladder in terms of potency, so effectiveness. But obviously it comes with a few more side effects. It can make you feel a bit groggy, really bungs your bowels up and things like that. So you want to start off with the things which have the lowest side effect profile, because if they work, we know those are sustainable for you to take with relatively few side effects, and then escalate up if those are not working. But once you go above paracetamol, certainly have a conversation with your GP, because some of those will need to be prescribed. You can buy non-steroidals over the counter, but just have a little think that they can cause adverse effects if you're taking lots of them long term. So just have a quick check with your doctor to make sure it's okay with what they know about your medical history.
That's great, thank you. We have a question around what your thoughts are on taking Ozempic when you have PBC.
Yeah, I don't think there's any evidence that it's harmful for you to do that. And I think, so Ozempic, for those who are not aware, is a drug originally developed to treat diabetes, type 2 diabetes. But it also has as a side effect, significant weight loss. And so it's increasingly being used as a weight loss intervention. So there's multiple reasons why people may be on it. And actually, if you're prescribed that medication, it is safe, it should be safe for you to take. The side effect profile from Ozempic is actually really, really good. And it shouldn't affect your PBC. It shouldn't affect your absorption of the various medications. And it might actually help you in the long run. I'm not saying a guarantee it will, but if you have if you're taking it for weight gain particularly, then, or if you've got already existing fatty liver from diabetes, then reducing some of that fat in the liver might help slow down the rate of progression of your scarring of your liver. Because if you have more than one thing that can be irritating the liver, then we know that's associated with a greater likelihood of developing progressive scar tissue, because you've got more than one process going on. So as a general thing, it's fine, but there might be specific people for whom they may well significantly benefit from taking Ozempic as well as so for PBC.
Great, thank you. We have a question about doing a liver cleanse and if that would help with PBC.
Not that we're aware of in studies. There's lots of these liver cleanses out there. I think the really important thing to remember with your liver is your liver is there to cleanse your body anyway. That's its prime purpose, along with your kidneys. So, as long as you're not harming it with alcohol or other substances, then really it's about using the medications that are treating the underlying PBC, are the things that are most likely to improve your PBC. So, there might be some new sort of alternative therapy that is developed in the future that shows evidence of benefit, but there's none as of yet that have been shown to do that. And because we're not certain about how these alternative remedies whether they affect absorption of existing medications, which we know are effective in this condition, we don't generally recommend people use them, and they can be quite expensive as well. So, I think, we're always quite cautious about those things because of the lack of obvious evidence around them, and the potential for them to interfere with things which we do have evidence for.
Yeah, thank you. Following up just there on what we were talking about earlier around the dry mouth, someone has asked, what do you ask the rheumatologist to do? You'd mentioned about the referral to the rheumatologist for further tests. So ask him what they ask that, and also, can your liver consultant refer you to the rheumatologist?
Right. So in the first one, you tend to do more. The test is a bit easier to do. There are salivary stimulation tests, and we probably send more people to the maxillofacial team for those sorts of tests. For the eye tests, the rheumatologist will do them. It's called a Schirmer test, and it's a really, really high tech thing where they literally just get some blotting paper and just see how far the tears travel over a period of time. Okay, it's extremely high tech, and I don't know why it's always sort of sat with the rheumatologists, probably because most people with those problems also have joint problems, I suspect. But But in many people, you can make a reliable diagnosis just on the severity of the dry mouth alone, and a quick examination of the neck to make sure there's nothing else that's causing a salivary gland problem. But the maxillofacial team will often be involved with that if the GP thinks additional testing is needed. What was the second part of the question, Mo?
Can your liver consultant refer you to the rheumatologist?
Yeah.
So just how you would go about getting that referral?
Yeah. So in some areas, yes. In some areas, no. So where I work in Wales, there isn't a restriction on that happening. In England, I think it's very often that the GP will make that referral, and the liver consultant might direct the GP to make that referral, if that makes sense.
Okay. This patient has noted that they're in Spain, actually, just for noting that. The patient has noted that they're in Spain.
Okay. I'm not that familiar with the Spanish system, unfortunately, but I mean, in general, I think if you have contact with your hospital team, just ask them. So if you're having problems and again, they will know what their local pathway is. So as I say, some of the things around testing are historical rather than, the dry eyes is not a rheumatological condition, but because they tend to see more of it than anybody else, they've sort of organized the testing for the dry eyes. In other areas, it might be somewhat different. So your local team will know. I know where it sits within my local area, but there's a little bit of, chop and change depending where you are and probably different countries. So if you've got contact with your liver team, you can go to them and see if you're having joint problems in particular, or if you're really troubled by that, what additional testing might be needed and where that can take place. So the first thing to do is to flag it up to either your liver consultant, or if you haven't currently got a liver consultant, then your primary care doctor would be the person to be able to signpost you to where things would be best placed to happen.
Great. They did also note actually that their dentist did recommend the mouth spray, gel and chewing gum after. So it does seem that some of the dentists are helping in terms of the issues that you'd mentioned around that as well. Okay, so moving on.
If I was just going to say, sorry, very quickly, if that's not working and they've already had that, then probably a referral on to the oral health team may be beneficial in case they've got any other little tips and tricks.
Still worthwhile, yeah. Brilliant, thank you.
Because that's what I'd normally do, yeah.
So we have another question around ALT was at 160, AST 215, bilirubin 1.1 a month ago. They're now seeing quite a rise. So the ALT is up from 160 to 245, AST from 215 to 344, bilirubin up from 1.1 to 1.3. Doctors sent patient for a CT scan, but nothing found, no reason found for that. But liver area has been pain for a couple of months now. Is there something else we should be maybe looking at?
Good question. I mean, I think certainly the CT scan is, if you've had that done, that's reassuring that there's nothing new and worrisome in the liver, and it's a pretty good test at looking for most things you'd be concerned about, that's not related to PBC. So I guess, I mean, the ALT is a bit higher than we typically see in PBC. So, it is possible that you might have one of these variant or overlap syndromes where there's an element of more than one of these autoimmune diseases that can affect the liver. I think in general, there's a bit of controversy about whether those things truly exist or whether there's just one disease that's behaving and looking a little bit more like the other. So I think the key thing with that is that needs to be looked at to see whether there might be some sort of overlap. Some people, if they've got worsening tests, might end up needing a liver biopsy to be able to differentiate that, but that's a decision only obviously your healthcare professional can make. The other thing as well is that, are you adherent to your medication? Are you taking your PBC medication? And if you are taking that regularly at the right dose, so I'm thinking mainly around Urso now, if you're taking that at a dose of 13 to 15 milligrams per kilogram. So most people will be able to work that out with a phone calculator. If you're taking that appropriate dose, then the questions really need to go back to the doctor and say, well, okay, my liver tests are higher than they should be with this condition. Am I on the right treatment? Am I on the right dose of that treatment? And if I am on the right dose of the initial treatment, are there additional treatments I need, or are any other further tests I need to try and identify whether there's an overlap syndrome here and there's an element of more than one condition. So there's a couple of things going on there. The CT scan is reassuring that there's nothing more worrisome, but in terms of actually what's driving that increased inflammation in the liver, I think it's important that that gets to the bottom of. and it will probably require further testing just to try and understand exactly what's going on. And some doctors may recommend a liver biopsy, so don't be alarmed if they do that. That would be a relatively common thing, but they might have enough information to not need to recommend that. But if they do, don't be too alarmed. It's quite normal practice in this sort of situation.
To get a bit more detail. Great.
To get a bit more detail.
Yeah. So we've got a question around cholestyramine. Does it affect the absorption of other drugs besides urso?
Yeah, it does. So one of the challenges with cholestyramine is that you have to take it at a time distant to all your other medications. So you've got to make sure that you know, and the best thing to do is, because obviously the pharmacist who's dispensing the medication will know what else you're being dispensed, and knows, because some medications are empty stomach, some are taken with food, and so it can become a real pain in the backside then, can't it? If you're taking your urso 3 times a day, and then you've got to take your cholestyramine twice a day, and you've got a tablet you have to take on an empty stomach, you have to take a tablet after food. You're like, well, where the heck do I fit all these in? And it can be a real challenge. But certainly cholestyramine, it is a binding agent, okay? So it really does affect the absorption of other medications. So it's really important that if you're prescribed that you check in with a pharmacist when you're picking up about the optimal time to take it in conjunction with all the other medications that you're taking. So yeah, run it by the pharmacist when you collect your medications would be my advice.
Brilliant, thank you. We do actually have a couple of questions that I have from previous sessions to pick up that was mentioned around, you touched on the urso dose there. So a couple of questions around the urso dose. So one is, patient has gained weight since diagnosis, but doctor advising no need to increase as their bloods are fine. So their urso calculator is showing that their dose should be 1,000 milligrams, but they're on 750.
Yeah.
Should they push for that? What's your thoughts on that?
Yeah, we don't have definitive information on it at the moment. I think I don't. If the ALP is normal, I don't increase the dose, because I don't think there's any evidence of making it even more normal is better for people. There's no evidence that makes a difference. The challenging thing is that we've become a little bit obsessed about getting the ALP below 200, which is good, but actually we haven't always pushed on to making it normal. And the question is whether, say your ALP is, because normal is usually about 130, 135. What happens if your ALP is about 170 and you're not on a full dose of urso? Would taking the full dose get it down to normal? So my general practice is, if people are tolerating the urso well and the ALP is above normal to any degree, I will increase. But if the ALP is completely in the normal range, I wouldn't increase.
Okay. That makes sense. Yeah. One of the other questions just on the back.
Yeah, I can't support that with any evidence at the moment. It's all extrapolation. But I think if you've completely normalized your liver tests, I don't see any value in increasing at all. But I think, if it's slightly abnormal and you're tolerating okay, it's perfectly reasonable, I think, and sensible to increase to the full weight-based dose.
Great. And then another question, just following on from that, is around, can you alter your urso dose yourself, or do you need to get your doctor to do it? So obviously we have the urso calculator that says what your dose should be, and people will have the medication at home, but it would always be better to discuss it with your doctor. Yeah,
I think the resources from the foundation can be helpful for that, because I think, probably sharing those with healthcare professionals who don't see as much PBC is helpful, because the PBC Foundation resources are all produced in conjunction with clinicians. So it's not, so there's that element that it's been approved by medical specialists in this field. So I think I would go down that route to begin with. Again, the urgency to increase it's not a condition where it's not like treating acute asthma where you have to get on top of it really, really quickly. So there is time to make that change. And of course, if you're increasing the dose of your urso, say you're going from 3 to 4 tablets a day, you're going to run out very, very quickly. And your GP is going to want to know why you've run out, instead of at 8 weeks or 12 weeks, why you've run out at 4. So I would generally say, go along and say, oh, look, current guidance is I need to be taken at this dose. I've gained weight. Do I need an increased dose? And they should respond to that sort of polite request to do that. And it's better to do it that way, so you've got the requisite amount of medication and you're not running out then. The other question about urso is, is how to take it. And if you look at the license, it says to take it 2-3 times a day. The reality is lots of people take it all once a day, and that's okay too. And I think so. I'm not too bothered about whether some people just find it easier to take it all in one go. The only downside is that you're slightly more likely to get some diarrheal symptoms if you're taking all that medication in one go. But if you're not, and you're managing that okay, and it's difficult to balance it with other medications like your cholestyramine and all your other things, sometimes bundling all your urso together and getting it all out of the way is perfectly acceptable to do.
And just building the routine and habit of that, isn't it? And then you're remembering and you're taking it all. There's actually another question just on the similar lines to that. So a new patient who's starting their urso is asked, is it okay to start the urso slowly and build up to the full dose over a few weeks? So if there is a bit of a concern about diarrhea or any other symptoms, is that acceptable to start it and build it up?
It absolutely is, because it's not a medication that works really quickly. As we know, urso takes probably about 3 to 6 months to have its, most of its effect, and up to 12 months in some individuals. So it's relatively slow acting medication. And it's I think it's perfectly acceptable to build it up. My personal practice is I don't do that routinely, but of course, when you're speaking to some people just tolerate medications badly. It's not their fault. It's just their body just doesn't like when they take medication. It causes get upset or whatever. And so if I see people and they say, "Oh, look, I don't like taking tablets because they have lots of side effects," then I will nearly always say, "Okay, yeah, let's go slow here," and I'm more likely to split the dose as well. So I'm more likely to start at a lower than optimal dose, and I'm more likely to split the dose, as in, when I say split the dose, taking it 2 or 3 times a day, then take it all in one go. Because if you're giving the body less of a hit in one go, they're more likely to tolerate it. But some people, if you're managing at the existing dose and it's the full dose, then you can just carry on. But yeah, it's perfectly okay to sort of build up, particularly if you've tended to have problems with intolerance of medication in the past. And coming back to that early question, wasn't it, is that person doesn't tolerate some constituents of what might be in the urso medication, then sometimes starting off a low dose will give you confidence that actually it's not affecting you, and then you can build up that way. Because it's really important you have confidence in the medications that we're prescribing you, because if you're not taking them optimally because you're getting side effects from them, then it's not going to be doing you the best.
And if you are worried about that, starting it and building it up seems like a really good solution for that. So that's great. One more question just around the urso dose and the weight for that. So a patient weighing just over 57 kilos, so based on so it's between 13 and 15 milligrams per kilogram. So if they were on 13 milligrams, then they would be in the 750 milligram bracket, because that would be 741 milligrams. But if they were on 15 milligrams per kilogram, they would be in the 1000 milligram bracket at 855 milligrams. Does that matter?
It depends on the ALP, I think. So I think if your ALP is normal, I'm less bothered. So I would say if you're, I think we should probably push. It's difficult because once a drug is registered a certain thing, the company has to go through a ridiculous registration process to get that official recommendation changed. I think we're better off just saying everybody should be on 15. It's an easier calculation. You can sometimes do it in your head, isn't it? It's times by 10 and half again, and then you've got your dose.
To work it out,
yeah, exactly. So, but we are where we are with that sort of range of weight-based dosing. So for me, it's about, are you meeting the response criteria? And I think if you're meeting the response criteria, there's less of an urgency. But I think certainly for me, if the liver tests are above 130, but less than 200, and your weight-based dosing suggests that you should be on 780 rather than giving you 750, I'd probably go for the 1000.
It's a bit like the other question, isn't it, as to whether or not you should push to get it increased. It is around what else is going on around your ALP, isn't it?
Yeah, and in PSC, they have done trials of super high doses of urso, and as it happened, it didn't make any impact. Actually, potentially in that condition, might have made things worse. But in other conditions, you can use much higher doses of urso than 15 milligrams per kilogram. So, it's not uncommon for people to have 20, 25 milligrams per kilogram of urso. So, in other words, it's, as long as you're tolerating okay, it's probably better to give a bit more than you need than a bit less than you need. But the key is, are you responding to it? and have you got the desired ALP response? And if you have got the desired ALP response, I don't mind if people are actually on 11.5 milligrams per kilogram, you know? So when OCA became available and we knew we had, when OCA became available and we knew we had second line options, we looked back at everybody in my area that hadn't, you know, who has PBC, and we looked at whether people were on the right dose of urso to begin with, and we found quite a lot of people weren't on the right dose of urso, but the commonest reason people weren't on the right dose of urso wasn't because we hadn't put them on the right dose, it's that they'd previously, years ago, been started on a much lower dose. Some people were on 8 milligrams per kilogram, but their liver tests were normal. So we didn't change it because, you know, you've had the desired response at a lower dose. The reason why we set it now is because we're trying to look forward and we can't predict what's going to happen to that person in the future. Whereas all the people in the past, we kind of know how they've responded to it. So we know that they've responded really, really well in 6 to 12 months. So we know they're low risk. We know they haven't got advanced liver disease. So we know that they tolerated that well. But for future people, then we would always start at that starting point because that gives you the best chance of having an optimal response to urso and not needing second line therapies.
Great. I've just had a couple of questions sneak in on Facebook. Could we just sneak those in if that's okay? We've got one question from a patient who's saying, have you had experience with patients that have had pain that they only help to relieve any pain is from taking antibiotics? They're feeling so much better after taking them, but the doctors don't seem to know why. So as to why the antibiotics might help with pain. No specifics around the type of pain or where the pain, but just pain.
So, I mean, some people get, from a PBC perspective alone, PBC shouldn't really cause liver pain in itself, because it doesn't affect the really big bile ducts that often lead to the problems with infection. PSC is very different, where you get lots of pain that antibiotics will make it better. So the first question you would ask is, be certain it's the right diagnosis, that is PBC and not another disorder of the liver that can affect the bile ducts like PSC, because bouts of pain will definitely get better with antibiotics in that condition. So it's always to question the original diagnosis. Second thing is, if the original diagnosis of PBC is completely sound, there might be other conditions that are not related to PBC at all that might be causing pain. So some people can get bacterial overgrowth in their intestine that cause bloating and discomfort. And short courses of antibiotics can improve that. So if you get a lot of bloating, you get change in bowel habit or fluctuating bowel habit with diarrhea and discomfort and fluctuating bowel actions, then that can be a sign that you've got what's called bacterial overgrowth, and antibiotics can be helpful for that. So it might be something completely separate, but that would still warrant further investigation and further review. So I think if you're getting something like that, think and try to be as specific as you can about where the symptoms are located, which part of the body, how frequently they occur, how quickly they get better with the antibiotics. Is there a particular antibiotic that seems to make it better? Because this is most likely, if you definitely have PBC, this is most likely to be something completely separate, but would warrant further investigation to get to the bottom of that, so you can have an optimal treatment plan in place.
Great, thank you. And on to the last question, which is about a recently diagnosed patient. So their mum was diagnosed with PBC recently, and they're trying to gauge what stage she's at, whether it be 2 or 3, but she's horrifically symptom and her pain is so bad. Stomach and joint pain just seems to be getting worse. Is there anything out there that she can take to help ease those symptoms? And they're all at a loss in terms of the families to know why she's so heavily symptomatic.
Yes, so I think if I answer the first part first, and then we come on to the bit about the symptoms. So in terms of stage, I mean, I think we don't routinely do liver biopsies in PBC like we used to many, many years ago. And so they may well be able to stage via doing a FibroScan or an ELF test, which is a serum test, a blood test to gauge how much scar tissue is present in the liver. So that might be one way of staging the underlying PBC. Coming back to a point I made a bit earlier, is that the presence of scar tissue in the liver is not associated with the severity of your symptoms in PBC. And some people have horrendous symptoms and no scar tissue in the liver. And think, well, how can that be? Surely if my symptoms are really bad, my underlying liver disease must be really bad. Yeah. You can have really bad symptoms and really bad liver disease, but you can also have really severe symptoms and have no scarring whatsoever of the liver, and even the liver tests themselves are only very mildly abnormal. So I think in that sense, it's really important to disassociate the severity of symptoms from assuming that that's related to really, really bad liver disease, because it's often not the case. Nonetheless, it sounds like they need to go through a process of working that out for you. Mm-hmm. In regards to the symptoms, again, I'd come back, if you're having really severe joint pains, then it's important that you have a proper evaluation to make sure you haven't got an associated arthritis, because that can have a very different treatment option. Because coming back to my earlier point, the symptoms that you get associated with PBC are not made better by the medications we give to treat PBC. If you have a joint condition, though, they might use other, sometimes quite potent immune suppressant drugs to control joint inflammation, and those can be spectacularly effective if you have one of those conditions. Coming on to pain, it depends where the pain is. If the pain is associated around the joints, really focusing on getting further assessment of the joint problems, and that's likely going to need to be with a rheumatologist. Mm-hmm. If the pain is elsewhere, it's about where is it? Is it in the gut? So gut dysfunction is quite common in the general population. So either as an IBS or as other specific conditions, and they are more likely to occur if you have another chronic condition, whether that's PBC, rheumatoid arthritis, or inflammatory bowel disease. You're more likely to have gut dysfunction if you have another chronic disease. So try to be as specific as possible with your doctor then when you go and see them, where that symptom is, what are the exacerbating and relieving factors, is it constant, is it intermittent, anything that makes it a little bit better, whether it's something you've taken yourself or this with exercise or with rest or whatever, so that your GP in the first instance can probably get you to the answers you need to try and get things better, because it doesn't sound like all those associated symptoms are going to be made better by treatment for PBC, because they're probably not directly related, and they might be associated conditions that require different investigations and different treatments for.
Mm-hmm. A bit more detail. What I would say as well is that's quite obviously the patient's quite newly diagnosed. So just to remind and say directly as well to that patient that our helpline's available as well if anyone would like to have a chat with us, and we can look into things on a bit more of a personal level for them, because we are aware that when we're chatting on at these sessions, it's more sort of general advice. So please use our helpline if anyone would like to have a bit of a further chat on that. So I think we've got through all of the questions that came in advance, and also all the questions on Facebook today. So thank you so much for your time. We really do appreciate it. And just to say, if anyone has got any other questions, please just send them in to us. We've got one more session before the end of the year, and then we'll collate any questions for the new year as well. So thank you so much for that, and thank you again for your time. Really appreciated it.
Yeah, very welcome. Merry Christmas all.
You too. Take care. Thank you. Bye.